صباح الخير على حضراتكم. بشكر الاورجنايزرز بتاع المؤتمر لدعوتي للبرزنتيشن. ده شرف ليا، وبشكر طبعا حضراتكم والبورد الموجود واساتذتي اللي موجودين معايا. يعني النهارده هنتكلم سريعا كده عن اكسبيرينس بتاعت عين شمس في البروجرام بتاع المينيمال انفيزيف مايترال سيرجري. شويه تيبس كده يعني بنقولها للناس من الاكسبيرينس بتاعتنا، ونجو ثرو الموضوع ده سريعا ان شاء الله. دي صوره لاكاديميه القلب كما نطلق عليها، مستشفى امراض وجراحات القلب اللي انا بتشرف ان انا بأديرها في الوقت الحالي، وهي بيتنا الكبير اللي كلنا بنحبه وبنشتغل فيه. I have no conflict of interest. The objectives of this presentation is to know the definition of minimal invasive mitral surgery, quickly go through advantage and disadvantage, the official classification and various incisions for the minimal invasive mitral surgery, how to do a proper patient selection, especially when you're starting a program with the junior doctors, and allow them to operate safely. Some tips about the anesthesia and how to monitor the patient, and some of the basic instruments and very fundamental instruments that have to be available for the patient safety. Discuss quickly the operative techniques and our results. So the official definition of the minimal invasive mitral surgery is that any incision, any operation on the heart that can be done without using the cardiopulmonary bypass or without a full median stenotomy is considered as a mitral minimal invasive procedure. As for mitral valve surgery, we have to operate using the cardiopulmonary bypass. So various incisions have been proposed to overcome the other issue. Of course, we all know the advantages of the minimal invasive procedures: small incision, more appealing to the patients, more cosmosis, less scar, less post-operative pain. It significantly reduced the intensive care unit stay and the total hospital stay. There is a decrease in the post-operative respiratory dysfunction the patient can suffer with a conventional median stenotomy, less chest instability, and less incidence of wound infection, and less requirement for blood products, and as there is usually less and significantly less bleeding post-operative. So Carpentier and Lulmé were the pioneers in inventing minimal invasive surgery, minimal invasive cardiac surgery. They started the practice in the late 90s of the last centuries. So they classified the degree of invasiveness as 4 stages. Level 1, they considered doing a 10 to 12 incision along the lateral thoracotomy as a first level, or level 1 of minimal invasive surgery, through which they could operate on the mitral valve. And then they progressed in reducing the size of the incision, going down to 4 to 6 centimeters, usually through direct vision or sometimes assisted by the video endoscopy. Level 3 is what we call the port access, or depending totally on the VATS tower and using the cameras to visualize. And level 4 is the robotic surgery. So this is a picture of a level 1. That's how we do a left thoracotomy to operate on the mitral valve. And this technique has been done quite a long time at Ain Shams University. Normally use the central cannulation and the normal instrument. There is no need for special instruments for such operation. Making things a bit harder for the surgeon and more appealing to the patients is going through lesser incisions. We started the right mini thoracotomy approach, going down to the size of the incision between 4 to 6 centimeters. It gives excellent exposure to the valve, needs a bit of experienced surgeon. Generally, it has some disadvantage as requiring some special instruments. Sometimes it's difficult to extend the incision if any mishaps happened. And through this incision, you can only operate on some structures on the heart, like the mitral valve, the tricuspid valve, the ASD, and some cardiac tumors. I know there has been widening the practice and Dr. Tamer Mansour is able to operate on a double valve through this incision, but this goes on when you become more experienced. Then the robotic procedure, where the operator is sitting on the console and operating remotely through the valves using these instruments. So we have to have a patient. This slide summarizes the favorable criteria for minimal invasive mitral patient. And as we go on with our practice, we tend to be less strict with all these points. It's better, but for beginners to be strict to these recommendations and criteria, better to have a single valve, mitral valve pathology. We accepted no more than mild aortic regurgitation and mild to moderate TR, especially in our initial cases. The patient have to have normal coronaries. We did not operate initially on any redo patients. They were all de novo patients with no previous right thoracotomy to avoid the adhesions. We avoided patients with active infective endocarditis because we were concerned that there is extension from the mitral annulus to the aortic root. We selected the patients with minimal mitral annular calcification just for the ease of the procedure. And we used to ultrasound the femorals, make sure that the size of the artery is decent to accommodate a decent size cannula, usually from 6 to 8 millimeter. We selected patients with normal ejection fraction and avoid patients with high pulmonary artery pressure. Slim patients are technically easier rather than obese patients, although the obese patients do benefit more from this minimal invasive technique, but for the early learning curve of for surgeons. And we definitely did not include any patients with chest wall deformity like pectus because the heart is pushed greatly towards the right side, the left side, sorry. We have to have essentials, so this is a bit different than what Dr. Samer early in his presentation side. We're strict in having all the requirements we have. We need to have the special cannula for the bypass, the insertion kit, the long venous femoral cannula, especially the multi-stage, which provides a proper drainage, the long cardioplegia cannula, and the proper femoral artery cannula, the soft tissue retractor, and the adhesive pads for the DC shock. This is quite essential. Again, this is type of femoral cannula. If you're planning to have an endo aortic occluder, you have to have this cannula on this side with the side arm to insert the balloon occluder from this side, and the other is for the inflow for the arterial cardiopulmonary bypass. You have to have the proper surgical instruments, which is usually the long shafted instruments and the special mitral retractor. Aortic occluders, this is the sheetwood clamp, which we readily have and we use in most of our cases. And the other is the endoballoon occluder. I don't think anyone is using it much because of incidence of migration and dissections, which was reported by early use. Soft tissue retractor definitely improved the visualization for the procedure and makes things much easier, especially in obese patients. And in early practice, because the procedure was quite long, we elected to have the Castiglione or the Brett-Schneider solution, which provide a single administration, and we can safely operate on bypass between 90 minutes to 120 minutes without need to interrupt the procedure and give another dose of myocardial protection. If you have the facility of having a 3D video assisted, it greatly improve the visualization and make the movements and the fine movements much easier for you, and definitely makes things easier. Some adjuvants for the cardiopulmonary bypass, like the vacuum suction, which needs to be applied for the proper venous drainage. We find that without the use of this vacuum, the heart is not properly drained because the maximum size of femoral cannula used was a 23 flange. And if the heart is not drained, the procedure is much more technically difficult. You have to have an oxygenator that is sealed and compatible with the negative suction for the vacuum. So in our experience, we know that our early professor used to do the right thoracotomy for the mitral valve, which is considered level 1 of the minimal invasiveness. And in my practice, I did my MD thesis back in 2006 on the mini sternotomy for AVR. This is our early practice. And then when we started the mitral invasive program after we moved to the Cardiothoracic Academy in the late 2013, this is a copy of a proposal I did and Dr. Yasser Has. We put this criteria to have a fixed team for the minimal invasive program, fixed cardiac surgeon, anesthetist, scrub nurse, and all the cardiologist to refer the patient. The perfusionist is one of the cornerstones, and this is how we started the program back in 2015. I'm lucky that we have 3 of our head departments, Professor Dr. Ahmed Al-Kirdani, Professor Dr. Mohamed Al-Fiqi, and Dr. Mustafa Abdel Azim, who sponsored and greatly give us a hand in progressing through this team, this minimally invasive team. We started by having visits. This is a photo of myself and Dr. Ahmed Fouad going to Ulm University with Andreas Leopold. We used to have exchanging visits to know the tips and tricks and techniques for the mitral minimal invasive procedures. And we started phase 1 of the program. We used to do sporadic cases. There was not a fixed list. From 2015 to 2019, when we did not have this fixed team, we operated on a total of 73 patients. Most of them had mitral valve replacements. We do a few mitral repairs, P2 prolapse, few patients has ASD closures, and some atrial myxomas. We had no mortalities in this phase 1 of the program. We have no patients explored for bleeding. However, we have a bit of high conversion rate because mostly problems related to the femoral cannulation and some injury to the iliac veins, and a couple of patients developed wound seroma. And then we found that to have a fixed team of 4 cardiac surgeons will help definitely. So this is one of our recommendations. If any center is starting this program, is to have at least 2 or 3 senior surgeons. They do share experience and make things less pressure on you in theater and definitely less incidence of complication. This team started in 2019, 4 senior surgeons. We started to have a fixed regular once weekly list, and we have a dedicated outpatient clinic to receive the patients. Some anesthesia techniques and monitoring, it's pretty much the same as the conventional. Sometimes we use the single lung ventilation endotracheal tube, although it's not always necessarily available. But the defib, external defib is mandatory. The TEE is mandatory, and the other lines are pretty much the same as the normal mitral valve procedure. The role of transesophageal echo is very important because it's the eye of the surgeon. We use it to assist and guide for the cannulation and make sure the proper de-airing and coming off bypass, it's greatly helpful. The positioning of the patient that he normally lies supines, the right side is a bit elevated. We used to drape to expose the right side and the front of the chest and the right groin. The external defib has to be applied on the back end towards the apex of the lung. The operative techniques, as most of us know, it's 4 to 6 right minute thoracotomy in the 4th or 5th intercostal space. We usually assign for the middle. We don't measure exactly the space. We just go for the mid of the chest, usually lateral to the nipple on male patients, and inframammary skin crease in female patients. And we use the sheetwood cross clamp in all our cases. Using this technique and with this team, we operated almost on 270 patients, 270 patients, sorry. Mitral valve replacements, tricuspid valve replacement, ASDs, left atrial myxoma. We did some of double valve replacements and few mid caps from the left thoracotomy. This is what we operated since the team was formed now. Our results were pretty much good. We had no mortalities. We had no exploration for bleeding. We had 1 patient who had to extend the thoracotomy to control bleeding from the main pulmonary artery. Some of the patients had superficial wound infections, phrenic nerve palsy. 1 patient had pleural effusion, and 1 patient had prolonged ITU stay for a bit of myocardial suboptimal protection. We had to struggle with inotropes for a bit, but she was discharged fine after this. Blood loss was significantly less than the conventional mitral replacement. Most of the patients bled almost less than 200 mL per hour, and this was reflected on the amount of blood transfusion they needed. Most of the patients were extubated early after the first 6 hours after the operation. Hospital and ICU stay were significantly less. ICU stay were normally about 1 day, and they were patients who normally discharged on the 5th day. This is just 1 more slide. So this is the shape of the scar in a male and a female patient. This is how the scar in females is pretty much inframammary, so it's much cosmetic, and in males it's it tends to shrink after 2 to 3 months of the operation when the scars start to contract. So this is where we stand. We're almost touching level 3 in doing most of the cases using the endoscopes and getting less size of incision. And our future is to widespread the practice of the minimal invasive mitral program to include AF ablation, total coronary revascularization, and to attract more surgeons to the team. And maybe one day we'll have robotic surgery. So right mini thoracotomy is quite appealing and it's doable, and I encourage all the centers to try this program. Thank you so much.